Hey, good afternoon, everyone. My name is Cedric Rutland. I'm a pulmonary critical care physician in Southern California. I practice a lot of autoimmune lung disease and a lot of interventional pulmonary. Now, what we're going to talk about today is we're going to talk about interstitial lung disease. More specifically, we're going to talk about chronic fibrosing interstitial lung diseases and how to diagnose these things. Boehringer Ingelheim has sponsored this presentation. I just want to let you guys know if you have any questions surrounding chronic fibrosing interstitial lung disease. Since this isn't a Q&A session and there won't be a Q&A session after the lecture, please ask your local rep or your local MSL and they will help with those questions. With that being said, we're going to go ahead and get into this. We all know that interstitial lung disease is a real diagnosis. And for us that practice a lot of interstitial lung disease during the COVID-19 pandemic, it's been rather difficult. And again, as I had mentioned, this presentation is made on behalf of Boehringer Ingelheim Pharmaceutical Company, and the company has provided financial support for this program. The content has been reviewed for consistency with FDA guidelines. So when you look at the COVID-19 pandemic, it's obvious that it's had global medical ramifications, right? It's led to refined prevention, treatment, and containment strategies to prevent infectious respiratory illness from traveling throughout the world. But among patients with COVID-19, we all know that over 80% of them present with mild symptoms: fever, cough, shortness of breath, right? 14% of those patients have respiratory distress and actually develop hypoxemia, and 5% of those are going to end up in our ICUs in respiratory failure, right? And so when we look at that, 2% of those COVID-19 patients have another pulmonary disease, which is associated with poor outcomes, likely because if you have the presence of another pulmonary disease, you're not going to have that reserve to be able to withstand another attack on your lung. So a lot of these patients that have underlying lung disease, they're going to have higher risk of severe complications. And we got to find a way to deal with those kinds of things. When you think about interstitial lung disease, we know that interstitial lung disease and COVID-19 can present in a very similar way, right? So it affects the care of interstitial lung disease patients. In fact, in my own clinic, I have to beware for those patients, right? Because those patients are on heavy medications, and that diagnostic process of whether or not they have COVID-19, I have to differentiate between whether it's COVID-19 or whether it's actually an interstitial lung disease exacerbation. And we already know that COVID-19 infection can trigger interstitial lung disease exacerbation. I've seen that personally in clinic, and I've also read about it in a significant number of case reports that have been published. When you look at some of the literature surrounding COVID-19 and interstitial lung disease, you want to know some of the clinical characteristics of these patients with pre-existing interstitial lung disease. In a single center retrospective study, about 30 patients with COVID-19 with pre-existing ILD, fever is the main symptom. We know that. Cough, sputum, fatigue, shortness of breath, diarrhea were frequently observed. Again, SARS-CoV-2 can not only infect your type 2 pneumocytes, it can also infect your epithelial cells in your small intestine, leading to that loose stool. Lymphocytes and lymphocyte subsets showed no significant differences compared with COVID-19 in patients without an interstitial lung disease. CT images suggested no differences in characteristics reflecting disease severity. In other words, you can't really say, oh, if we see this, it's definitely going to be this severe. When you look even further, compared with patients with COVID-19 without interstitial lung disease and patients with COVID-19 with a pre-existing ILD, the patients that had COVID-19 with a pre-existing ILD had greater neutrophils and monocytes. They had greater levels of their cytokines that led to significant inflammation, interleukin 8, interleukin 10, interleukin 1 beta, and they had coagulation dysfunction markers that were elevated like D-dimer. When you look at the CT scan, you might see intralobular interstitial and intralobular septal thickening. Again, you're also going to see honeycomb shadows on CT images as well. And I think it's just important to talk about COVID-19 and interstitial lung disease, as COVID-19 can present in that way. Patients with interstitial lung disease, they're at increased risk of mortality from COVID-19 compared to patients without interstitial lung disease. Now, there's one thing I want to say about this multi-center study. Within this multi-center study, which included 160 patients with COVID-19 and about 325 patients without a prior diagnosis of ILD. I want you to know that we don't know whether or not these patients were actually treated for their interstitial lung disease or not, right? Which can make a significant difference. But when you look at the mortality rate in patients that had ILD versus non-ILD, you can see that the patients that had interstitial lung disease and developed COVID-19 did have a higher mortality rate than those without interstitial lung disease. And I want to make certain that people understand that we don't know whether or not these patients were treated for interstitial lung disease. The CDC provides a framework for non-COVID-19 clinical care during the COVID-19 pandemic. And so again, when you have patients that have significant life-threatening diseases, you're obviously going to proceed with typical management. When you have patients that have less life-threatening diseases, we tried to not delay care, but organize care in such a way that was safe to reduce transmission of possible SARS-CoV-2 to other people that would lead to more significant COVID-19. And that becomes very obvious, and we've all practiced that for now the better part of this last year. And I know you guys understand that. Again, other practical approaches to operating effectively during the COVID-19 pandemic. You want to have implementation of infection prevention and control practices of COVID-19. So, make sure that you have PPE available, right? You want to have walk-up testing booths with transparent panels, allowing healthcare providers to collect samples for COVID-19. You want to use evidence-based care of patients with COVID-19. Use telehealth strategies when you can. I know I do telehealth almost every day these days. You want to be able to have patients have access to the phone so they can talk to you about their clinical illness. You want to implement plans of cohorting patients with COVID-19 and assigning dedicated staff to these patients, because you want to work towards resuming and maintaining their essential healthcare services. Just because they have COVID-19 doesn't mean you're going to ignore everything else. We still have to look after all of their other chronic medical problems while also managing their COVID-19. You want to maintain awareness of the COVID-19 situation within your region and your own facility. Now we're going to get into the meat and potatoes of this, right? We're going to talk about recognizing chronic fibrosing interstitial lung disease with a progressive phenotype. This is something that is near and dear to my heart because I have a love and a passion for interstitial lung disease and interstitial lung disease with progressive phenotypes in general. Again, we know that this presentation is made on behalf of Boehringer Ingelheim Pharmaceutical Company, and the company has provided financial support for this program. The content has been reviewed for consistency with FDA guidelines. So when we look at interstitial lung disease, all right, there are a diverse group of conditions that may result eventually in lung fibrosis. But more importantly, we got to understand what the interstitium is. So when we think about the lung, the way that the lung is organized, the basic unit of function of the lung is called the secondary pulmonary lobule. Now, if you can think back to when you were in medical school, when you're in residency, and you're drawing out the lung, when you outline the secondary pulmonary lobule, you have interlobular septa, right? It's kind of like a pentagon shape. And in the center of these interlobular septa, they're surrounding a bronchial and a pulmonary artery in the center of this secondary pulmonary lobule. And what you have surrounding the secondary pulmonary lobule is a bunch of alveoli kind of stacked on top of one another. So what we're talking about is disease in the interlobular septa and in the alveoli, right? Since the alveoli is essentially your capillary membrane, talking about disease there. There are over 200 well-described interstitial lung diseases. There's idiopathic interstitial pneumonias. That's where IPF is, NSIP, DIP, LIP, all right? Acute interstitial pneumonia is there. We also have pleural parenchymal fibroelastosis is there. You also have hypersensitivity pneumonitis, right? Hypersensitivity pneumonitis is a type 3 or 4 hypersensitivity reaction secondary to your lymphocytes due to an exposure of a certain antigen that your body looks to and looked at as harmful, and it activates an inflammatory response within your lung, causing inflammation and scarring. Looking at other autoimmune diseases, right? These are connective tissue diseases, rheumatoid arthritis, systemic sclerosis, polymyositis, lupus. All of these interstitial lung diseases, autoimmune lung diseases, all these diseases can damage the lung. So it's very important to screen these people. And more importantly, there's a new entity that we call interstitial pneumonia with autoimmune features, in which you have evidence of an interstitial pneumonia, you have ground glass opacity, you have scarring of some kind, and you may have an antibody that's positive, but you don't have those systemic manifestations yet. Sarcoidosis falls in interstitial lung disease. We know that that's a granulomatous disease as well. And then there's other interstitial lung diseases, including drug-associated interstitial lung diseases. I bring that one up first because with all of the invention of all the new cellular communication inhibitors that are going to inhibit the communication of cells that lead to cancer, you're going to have side effects and you're going to have a drug-associated interstitial lung diseases. Pulmonary, Langerhans cell histiocytosis is in there as well. Occupational lung diseases are there. Eosinophilic pneumonias are also there. What's important to understand is that fibrosis of this inflammation can develop, right? And that makes this process more progressive. So when you look at the inflammation in your lung, there is a point in time in which you get this epithelial to mesenchymal transition and you start laying down this collagen and you start developing fibrosis. And that process can happen in any of these interstitial lung diseases. Any of these interstitial lung diseases. That's why it's important to recognize them early and perhaps do something about it. When you look at the pathogenesis of the fibrosis, when you look at that pathogenesis, what you're going to have is you're going to have a break in that epithelial layer. Where the interstitium is, when you take that big breath of air in, that air is traveling down your bronchi into your bronchioles and eventually reaches your capillary membrane. If you're exposed to an antigen or something that causes a break in that epithelial layer, that's the initial insult that happens. We know that to be true. Normally, your wound is going to heal appropriately and you're going to have a normal functioning tissue. But what ends up happening is as a result of that break in that epithelium, what your lung does to heal is it tries to fill up that hole. But remember, your lung is full of a bunch of holes. It has a bunch of balloons. And so that fibrotic process just keeps on continuing and continuing and continuing. And you get this abnormal wound healing. And that leads to a reduction in your gas exchange. It's compromised. You can't do it anymore. So you're short of breath, right? All as a result of this break in that epithelial layer. And that's a problem. Think about the sum of clinical findings that you're going to have because of that initiation of that pathology, right? You're going to have dyspnea. Why are you going to be short of breath? Well, because you got that break in that epithelial layer and you've got this collagen laying down, this fibrosis taking place, so the alveoli can't do their job anymore. You might develop a non-productive cough because of the inflammatory mediators that are produced. People that have a history of interstitial lung disease in the family, or even people that have a history of connective tissue disease in the family, may present to you in that way. So you got to pay attention to that. And then on exam, you're going to hear crackles. You're going to see abnormal chest imaging. You're going to have a desaturation with exercise, and you really got to get these people to walk. You're also going to see low functional vital capacity, and you're going to see a low DLCO, right? You're going to see your lung is going to feel really, really small, and the gas exchange is going to be very, very poor. When you're looking for evidence of progression in these patients with chronic fibrosing ILD, what are you going to look for? Well, you're going to look for increasing fibrosis on high-resolution chest CT. And I say that because you really got to get that chest CT early. You're going to see a decline in their FVC. They're not going to be able to hold on to as much air because more of their lung is scarred. They're going to have exacerbations, right? They might have worsening dyspnea or cough. They're going to have a decrease in their exercise capacity, right? And the physician or patient can also decide, you know what, I think this is worse, right? Maybe you just see a subtle change. Maybe you can see a subtle change in the patient's behavior. Maybe the patient notices that they can't walk the grocery store aisles anymore, right? These all count as progression in their chronic fibrosing interstitial lung disease. And it's very important to define that. Even more so to define that, you also want to diagnose that. How are you going to do that? Well, you're going to look for restrictive lung defects, right? So that FVC is going to be low and that FEV1 to FVC ratio might be really high, right? Because they're taking a deep breath in and they can't take a deep breath in and they blow it out real quick. So they're breathing like, right? This afternoon, earlier today in my clinic, I had a patient that had developed SARS-CoV-2 infection in January, COVID-19, in the hospital for 5 days. I get an FVC today. Her FVC is restricted, right? Her FVC was like 0.6 liters, which is very, very tiny in this elderly female, right? And it's likely secondary to fibrosing interstitial lung disease. And that's what you're going to see. This middle spirometry, you're going to see this narrowed loop as a result of restriction. They can't take that deep breath anymore. That inflammation, that scarring is present where they can't expand that lung, right? That's going to be the issue. Patients who report shortness of breath should undergo complete pulmonary function testing. That is, they need to get their FVC, they need to get their DLCO, they need to get the ratio. And we need to have an understanding of what it means when you have restriction. You're going to have a reduced FVC. You're going to have a reduced FEV1. You're not going to be able to hold on to as much air, right? The concept is really simple. If you have inflammation and scarring in your alveoli, in the areas where you're supposed to have air, you can't fill up the cup anymore. You can't fill it up as much, so it's going to be very, very tiny. Your DLCO is going to be reduced because you can't gas exchange. You can't gas exchange anymore because you've got scarring in the way of that capillary membrane. The oxygen can't diffuse across that. It takes too long. So here's another important point, and this is why I do what I do, because we know that acute exacerbations may accelerate disease progression. So you may have somebody that's running along, doing just fine, stable, and then boom, they have this exacerbation and they go straight down, right? And their disease progresses to death. That can happen. You have people that have an exacerbation, they're doing just fine, they have an exacerbation, and then boom, they accelerate a little bit more. They don't accelerate to death, but you can see with your serial CTs every 3 or 6 or 8 months, however often you like to do it, more ground glass, more fibrotic bronchiectasis. And we're going to get into what those findings actually are. But it's important to understand that once you have that exacerbation, you can accelerate disease progression. So you may want to try to prevent it. Because after you have that exacerbation, your median survival is 2.2 months, which is absolutely horrifying for these people. Understand that a high-resolution chest CT is way more sensitive than a chest X-ray in detecting fibrosis. In fact, it's so much more sensitive that if I think somebody has pulmonary fibrosis, if I hear crackles, I don't even get the chest X-ray. Now, insurance companies these days, they make you get the chest X-ray first. Fine. But you need to get in the habit of ordering these chest CTs. I'm a pulmonologist. You guys are pulmonologists. Maybe you're rheumatologists out there. Maybe you're primary care providers that are out there listening right now. But as a pulmonologist, I want to be able to see what the lungs look like. As we see what the lungs look like, we're going to be able to tell where the fibrosis is taking place. Look at these two images in front of you. You're going to look at this chest X-ray, and most people would look at this chest X-ray and read this chest X-ray as normal. This person's had 3 weeks of sinus congestion, clear sputum production after running, short of breath. Look at the chest X-ray. Doesn't look too bad. Look at the chest CT. Ground glass opacity. Evidence of early honeycombing here in the bases. And you can see this here, right? So this is why I stopped relying on the chest X-ray to tell me whether or not somebody had fibrosis. You have to rely on a better test. And that test is HRCT. So the question should be, man, should I be ordering HRCTs a lot earlier than I am? And I guarantee you the answer is probably yes, right? When you look at the HRCT or when you order it, I want you to look at it. You develop a certain skill set to be able to look at your chest CT and evaluate it yourself. Not to mention the fact that it breaks up your day and it's fun and it allows your day to be more diverse, right? So when you look at the chest CT, what are you looking for? So you're looking for reticulation. What is reticulation? All reticulation is net-like. That is, it follows the secondary pulmonary lobule. So when you draw out that pulmonary lobule, you're looking for evidence of thickening in the intralobular septa, around the bronchiole, around the pulmonary artery, okay? Or in the subpleural regions, right? That's reticulation. Honeycombing, just little black cysts stacked on top of one another. That's all it is. Here's honeycombing here in the anterior region of the lung. Not really consistent with IPF classically, right? We normally say that's posterior in the basis, but when you look at this, this is what honeycombing is. You also want to look for what's called traction bronchiectasis or fibrotic bronchiectasis. The way that I imagine that is what you have is you have this collagen scarring on the outside of your bronchioles, so they can't collapse anymore, right? That muscle can't constrict anymore. It just stays open and it's pulled open. You can see the traction bronchiectasis there. And when you see that, what you want to think of is you want to really start thinking of fibrosis and scarring around that bronchiole that keeps it open. right? That's what you want to see. So these are the key features of fibrosis: reticulation, honeycombing, traction, or fibrotic bronchiectasis. So now what we're going to get into is we're going to get into examples of chronic fibrosing interstitial lung diseases with a progressive phenotype. All right, so we had already separated this out, right? So these are examples of interstitial lung disease groups identified as being potentially progressive. Idiopathic pulmonary fibrosis has an unknown course, right? The most common of the idiopathic interstitial pneumonia, all right? Hypersensitivity pneumonitis, which I think is an important diagnosis. Hypersensitive allergic reaction. You want to remove the antigen because that creates better outcomes if you can discover what it is. Autoimmune diseases, right? So immune-mediated damages. So in these patients, rheumatologists are going to be taking care of them. Pulmonologists are going to be taking care of them. You got to call each other on the phone, you guys. If you're a rheumatologist, if you're a pulmonologist, you need to be talking. My rheumatologist, I talk to every single day of my life. Like, I talk to her all the time because I want to be able to come up with a plan for these patients that have immune-mediated damage, right? Sarcoidosis, we know it's a granulomatous disease, right? What's causing it is being argued all the time on a daily basis. Doesn't matter. We know how to diagnose it, and we're treating it as an interstitial lung disease. And then there's an unclassifiable interstitial lung disease. Whether it's unclassifiable because we couldn't complete the workup because the patient said no, or the patient couldn't go through a certain thing, or it's unclassifiable because when we perform the workup, there's a lot of different features and we can't really say it's this or it's that. And these are the 5 groups that we like to represent these interstitial lung diseases and these progressive phenotypes. All right, they're not all inclusive of all fibrosing ILDs, okay? Other than IPF, only a percentage of these patients will experience progression. But it's important to understand, at least in my mind, that this chronic inflammatory process that's been initiated as a result of diagnosing their interstitial lung diseases is likely ongoing, right? And you want to know when it flips to that mesenchymal transition and you start to get that collagen and that laying down. IPF is the most common idiopathic interstitial pneumonia, right? What is it? Well, idiopathic pulmonary fibrosis is chronic fibrosing lung disease, interstitial pneumonia of an unknown cause. Most of these people are previous smokers or smokers. It's got a 5-year survival rate that's worse than most common cancers. I mean, look at this, 30% 5-year survival rate, right? Worse than breast cancer, and it's worse than colorectal cancer, right? But it's on the order of lung cancer here. So although it's not a cancer, it's almost behaving that way. It's rare in the younger population, but it's still there. Males, as I said, former or current smokers, and you're over 60 years old. If you have an unexplained cough or shortness of breath, right, and you hear crackles, even though the chest x-ray is clear, you need to get an HRCT. You need to consider this. Here's the problem. 50% of patients with IPF are initially misdiagnosed. And on average, diagnosing IPF takes up to 2 years, up to 24 months, over 700 days it takes for someone to get diagnosed with IPF. What does that mean? Well, it means the HRCT wasn't done. You got to do that. All right. And look at these mortality rates per 100 person years, right? At the time of diagnosis, less than a year, it's only 8, right? If it's greater than 4 years for your time of diagnosis, mortality rate is 32. So you need to diagnose this early. And I can't stress this enough. If you're questioning somebody's shortness of breath, right, and they're still having shortness of breath, and you put them on all kinds of inhalers, which is what happens, you got to get in the habit of ordering the HRCT. If you're a primary care physician, you don't need me, a pulmonologist, to order the HRCT. You guys can order the HRCT. I will look at it, right? But please get in the habit of doing this. It's essential for diagnosing IPF because you want to be able to exclude other known causes of interstitial lung disease. You want to see if there's a presence of a UIP pattern on HRCT. Now, this can be confusing because UIP is a pathological diagnosis. That is, it's a diagnosis that you see under the microscope, but it's also a radiographic diagnosis, right? And those findings of UIP are going to be basal predominant honeycombing, right? Increased reticulation, right? You're going to have absence of other findings. You're going to have absence of upper lobe findings. There's so many different things that we consider to be UIP, right? But UIP is both radiographic and microscopic, all right? you can look at HRCT patterns, you can look at surgical lung biopsy patterns. I'm a guy that once you have fibrotic type of finding on your chest CT, I don't think that there's any reason to get a surgical lung biopsy. That's me, all right? If you have UIP findings, that is, if you read the radiographic report or if your pulmonologist is telling you, hey, there's UIP findings on the CT, there's no reason to get a surgical lung biopsy, I don't believe, all right? Unless you have a multidisciplinary discussion and everybody thinks it's necessary. IPF progresses over time. I want you to look at these two CAT scans, right? You got year 0 and you got year 3. So this is someone who presented, they've got some increased reticulation, they've got some early honeycombing on their CAT scan. We decide to watch and wait, and then 3 years later, they've got a little bit more reticulation. Looks like they've got a little bit of ground glass capacity. They've got some fibrotic bronchiectasis here. So we know that this progresses over time, and this is somebody that has a progressive pulmonary fibrosis here. You can see it right here. It's important for you guys to understand that this lung disease continues. It's not, oh, I have IPF and like that's it. It's, oh, I have IPF and we need to continue to watch them for progression, whether that's obtaining spirometry every so often, whether that's obtaining HRCTs every so often. We all have our ways of doing it, right? And I'm not saying any way is right or wrong, but you just got to watch it. Here's an acute exacerbation of somebody that has baseline IPF. You can see the increased reticulation. You can see the early honeycombing here. You can see the fibrotic retraction bronchiectasis there on the right lower lobe. And then when you look 5 months later, the patient presents to you in clinic or the patient presents to the hospital with acute shortness of breath and cough and not feeling well. You can see the increase in ground glass capacities. You can see more fibrotic bronchiectasis. You can see what an exacerbation is going to look like, right? And you can bet that the areas in which this inflammation is taking place may actually lead to more scar. So you want to diagnose key factors, right? There's key diagnostic factors, right? GERD, ex-smoker, no drug use. The PFTs are going to be restricted. The DLCO might be down a little bit. The TLC is going to be down. This guy's got serologies that are negative. He's 67 years old. He's got inspiratory crackles. He's got clubbing. When you look at his HRCT, you can see the reticulation. You can see the honeycombing there. You can see the traction bronchiectasis. Now, it's less obvious, right? More subtle in this CAT scan, but it's there. So it's really important for you to be able to read these things, right? Sometimes these patients get lost. I would encourage everybody, when you see your patient, you get a CAT scan, to read the CAT scan yourself and look at it. Let's move on to hypersensitivity pneumonitis, right? So hypersensitivity pneumonitis is an interstitial lung disease that can become fibrotic. It involves the alveoli and the terminal bronchiole along with the alveolar interstitium. This inhaled antigen, whatever it is, right? Out here, it could be pigeon feathers, pigeon poop, it could be farmer's lung, it could be many different antigens. It could be mycobacterium from your hot tub. The inhaled antigen is going to result in a delayed allergic reaction, all right? And when you have prolonged inhalation of a substance, this becomes more inflammatory and more inflammatory, right? The prevalence is about 2.5 people per 100,000, right? But you want to identify that antigen first, because if you can, it's going to impact survival. If you can remove the antigen, the survival rate goes way up. Occupational history is important here. Farming, like I said, gardening, okay? Even housekeeping, right? People that are cleaning the house, spraying all of those cleaners, that can cause hypersensitivity pneumonitis. I've seen it. Genetically, the avian antigen is associated with a single nucleotide polymorphism at HLA-DRB1, all right? You get the upregulation of the inflammatory genes, T-cell activation. T-cells are very important. Some of these patients with HP, it might be, or mostly non-smokers. Smoking seems to be somewhat protective. It's weird. But if they do have it, they have a higher mortality, which is crazy. But again, all these things can happen. And when you're working this up, right, you're going to get an exposure history. You're going to get an HRCT. The HRCT is going to have what's called mosaic attenuation. And it's just like it sounds, right? You're going to have areas of gray. You're going to have areas of black, which can represent air trapping, right? You're going to have traction bronchiectasis. You might have reticulation. You might have some honeycombing. You might want to get an HP panel in your area to know the common antigens that cause it. Just because your HP panel is negative does not mean your patient does not have HP, please. And Fibrotic HP, you're going to get scarring. Okay, you might have what looks like NSIP under the microscope or UIP under the microscope. And on BAL, if you do a bronch, you're going to see an elevated lymphocyte count. That is, you're going to have more than 20, 30% lymphocytes. You might have lymphocytosis in more than 50% of people. In other words, a lot of these people, they are going to have a lymphocytosis. Here are the CAT scan findings. On the left, you can see kind of this honeycombing type of distribution, all right? You can see some bronchiectasis. You can also see on the right in B, you can see mosaic attenuation. You can see the areas of black and the areas of light. Now, what I want you to do is when you look at this B frame here, you look at this B picture, this picture of mosaic attenuation is pretty dense. Like you can definitely see it. But this picture can also be very, very subtle. So I want you to imagine a situation in which the areas that look white are even a little bit darker. So you may not see it as much unless you spend some time actually looking at that CAT scan. It can happen. And so again, if it's lighter or if it's not as dense, perhaps the cellular infiltrate isn't as heavy and perhaps you have a chance here to intervene. I just want people to know that, all right? So always look for that mosaic attenuation, look for that air trapping, look for those ground glass opacities and that traction bronchiectasis in these patients. Again, patients might have a 25-pack-a-year history of smoking. They might work at a mill or in the industrial regions, right? I'm down the way from Long Beach. I'm in Newport Beach. I got to worry about that in those regions, okay? They might have a specific immunoglobulin panel that's positive. So you want to get that HP panel. The PFTs are going to be restricted, right? The TLC is going to be down. Their FBC is going to be down. The DLCO is going to be down. And histopathologically, you're going to see poorly formed granulomas on biopsy. When I do my navigational lung biopsies on these patients, I might see this under the microscope and say, yep, it's hypersensitivity pneumonitis. All right, so that does help and it can help. So autoimmune diseases, right? This one becomes a little bit more difficult because not all of us are used to diagnosing these things. I would encourage people to learn how to differentiate anti-synthetase from systemic sclerosis, from polymyositis, from NCTD, because I do think it's important because they are actually pretty common. All right, so you want to know what these serological markers are. In fact, I want you guys to screenshot this slide, look at the serological markers, go to your respective labs and say, how do I order these tests? And just have an interstitial lung disease panel, right? It's important to have it so that way the rheumatologist and the pulmonologist who's into this stuff can determine what autoimmune condition this might actually be and what CTD, interstitial lung disease, this is to determine a course of action in the future, all right? You also want to know if it's progressive and fibrotic, so you're going to want to get serial HRCT. These people might have crackles on auscultation. They might have positive serologies. Their ANA might be positive, and then their SSA and SSB may be positive for Sjogren's, right? They're going to have diffuse lung involvement on chest imaging. On HRCT, most of the time, it's going to be an NSIP type of finding. So when you go back to ATF, 2011, I think is when it was published, you'll be able to see in that ATS paper on idiopathic interstitial pneumonias, you'll be able to see radiographically what the different idiopathic interstitial pneumonias look like. That may be what you see on these patients. So just be able to look at that and define that, and be able to say, yeah, this is an autoimmune related interstitial lung disease or connective tissue disease, interstitial lung disease. So you might want to ask yourself, is there ILD on the HRCT? If there's not, you want to find a way to monitor it. Do they have cough? Do they have shortness of breath? Are you going to get PFTs regularly? The answer is yes. If it's there, you want to obtain further testing or involve a specialist. If you're a pulmonologist, you know what to do, right? If you're a rheumatologist, you know what to do. Obtain further testing. Get those pulmonary function tests. You can get a 6-minute walk. I'm not a 6-minute walk test guy, but you can get a 6-minute walk test. And then you want to do a self-reported dyspnea assessment, right? How short of breath is the patient? So you want to be able to help them in the best way possible, and you want to obtain as much objective data as you can so you can make an informed decision. Looking at the CAT scan, again, you can see the reticulation, you can see the ground glass, you can see the little bit of bronchiectasis here, all right? Again, you can see on the other side, there's also a slight mosaic attenuation that you can see on this UIP side over there, you can see the black and the gray area. But again, you're going to have these findings of UIP. In these autoimmune diseases, again, a significant number of patients with rheumatoid arthritis, interstitial lung disease, may actually have UIP. In fact, 15% of patients with rheumatoid arthritis do develop interstitial lung disease. It's not a small percentage, right? 15 out of 100 patients, that's a lot of patients that are going to have interstitial lung disease. And more than that, if their most common presentation is UIP, that's a lot of patients with progressive fibrotic interstitial lung disease. Raynaud's phenomenon, we got to remember what that is, right? Looking at the PFTs, they're going to be restricted. Look at the ANA, 1,640. SCL70, that's scleroderma, might be positive. The TPO is high. Again, when you're looking at this HRCT, it might be subtle because you might be catching it early, which is great. You can see the reticulations, you can see the honeycombing here, and you can also see the ground glass opacity. Don't just knock it down and ignore it because it's subtle. If it's subtle, there's a chance that it's going to progress. You need to have a plan to monitor for progression. So sarcoidosis, right? And again, I see a lot of sarcoid patients. It's a multi-system disease. It can affect the conduction system of the heart. It can affect your lung. It can affect your skin, right? So it affects mostly the lungs and the lymph nodes, and there's patterns of familiar clustering, all right? And when you look at specific HLAs, A1, BA, DR3, right, some of these patients are going to be more apt to having sarcoidosis. 20% of those sarcoidosis patients actually develop fibrosis, right? So we really got to monitor these folks, and you got to make that decision. One of the first sarcoid patients I ever saw in fellowship actually was one of the only people in the country to have a single lung transplant for sarcoidosis. It was actually quite interesting. This was in Kansas City, where I did my pulmonary and critical care fellowship at KU Med. But we have to pay attention to these folks, right? They might have GERD, hypertension, sinusitis. They might have a history of surgeries. When you look at their PFTs, their FVC may not be as low, right? Their TLC may not be as low. But when you look at the scan, you're going to see these subpleural reticulations. You might see some ground glass and some fibrosis. And when you biopsy them, you might see non-caseating granuloma, right? Sarcoidosis is one of those diseases that we hear about all the time, right? But that we don't really do a whole lot about most of the time. But we got to change that. We got to observe that, because if these patients become fibrotic, and 20% of them do, it's going to be an issue. So we got to pay attention to that. Some interstitial lung diseases are unclassifiable, right? The definition of this is the inability to classify the ILD despite a review of the clinical, radiological, and pathological findings during a multidisciplinary discussion. It's hard, right? So there's overlapping histological findings, right? There's we always want to fight between what features we're seeing clinically and radiologically and pathologically. There's significant overlapping. I don't mind when there's significant overlapping, because what it means to me is that doctors are getting together discussing, right? So it's important to have these types of discussions so you can get the patient on the right path as soon as possible, because that's what's important. Is it's important to be on the right path overall, right? Don't be upset because the ILD is unclassifiable. That should promote a discussion, and that's when people learn a lot. When you have an unclassifiable interstitial lung disease, what are you going to do? So is there a leading diagnosis? If there is, and you have a confident diagnosis, go ahead and give that confident diagnosis. Diseases don't read books. We all know that. We all try to be objective. We all try to follow certain algorithms to be able to diagnose it and be right. But again, what's nice about interstitial lung disease is the disease doesn't read the book, and you get to formulate a plan based on what this most likely could be, or based on what you know and what you're thinking about with other individuals. If you don't have a leading diagnosis, ask if there's a leading diagnosis that has more than 50% confidence. If yes, then you've got a provisional diagnosis and you might be able to classify this interstitial lung disease. If no, you've got an unclassifiable ILD, right? You want to document your differential diagnosis, but these people have a poor prognosis because you haven't classified them. Normally, when people don't classify, when people don't know, that usually means no therapy, right? They're going to have a poor prognosis. 2-year survival, 70 to 76%. 5-year survival, 46 to 70%. So we really need to follow these people because it might be just early. And so you just might need to repeat testing. I can't tell you how many times I drew, ANA and antibodies 3 years ago, And then all of a sudden this year, patient returns, they've got a little bit of progression. I run the test again and boom, one of the antibodies is positive. So then they must have had an interstitial pneumonia with some autoimmune features, or they had an unclassifiable ILD that I can now classify. So you just have to remember that just because it's unclassifiable doesn't mean there's nothing to do. So in summary, what we learned today was we learned how to diagnose many different chronic interstitial lung diseases, right? We know that they're characterized by exertional dyspnea and cough. That's easy, all right? You're going to be fatigued. You're going to see restriction. The thing about it that we learned was that on chest imaging, you want to get that HRCT because you want to diagnose that diffuse lung infiltration early. You want to know if your patient has idiopathic pulmonary fibrosis early. Many different interstitial lung diseases share similar symptoms, physiology, and radiographic findings, but you would like to classify them because the classification may dictate how the patient's going to proceed forward. When you look at disease progression, how are you going to diagnose disease progression? If the patient's more short of breath, if the patient has more fibrotic findings on CT, if the patient has a worsening pulmonary function test, if the patient's had an exacerbation, if the patient has a reduction in their exercise capacity, right? The progressive phenotype is pretty easy to define. So we have to understand that because of this lung damage, in terms of the cytokines that are first secreted because of damage, those might be a little bit different, whether it's interleukin 6, 8, 1 beta, TNF alpha. The final common pathway might be that epithelial to mesenchymal transition and that fibrosis. So the final stages of pathogenesis may all behave similarly, regardless of the insult or the cause. That's why I think it's important to diagnose that chronic fibrosing interstitial lung disease and that progressive phenotype early. I think it's very, very important. When you look at the misdiagnosis, it affects patient care. 75% of these patients had seen 3 or more physicians, 3 or more. 34% had a delay of 2 or more years in diagnosis. And that's crazy. 55% of these people had at least 1 misdiagnosis. 38% had 2 misdiagnosing. And that's the issue that we're facing. If you don't diagnose it early, that means you're not doing anything about it early. That means those people are likely progressing. But we are allowing an opportunity for exacerbations to happen and for disease worsening to happen. Multi-disciplinary discussions are recommended for diagnosing interstitial lung diseases. It can simply be a phone call. You can call your rheumatologist. You can call your pathologist and have a discussion. That's multidisciplinary. Just because you're the center of the discussion, you're the one making the phone call, doesn't mean it's not multidisciplinary, right? ILD centers have the resources and experience to manage a multidisciplinary approach because they have everybody under one roof, and they can probably have the residents and fellows kind of manage the services, and they can get together and discuss these things. But by that same token, if you're in private practice, you can go make a phone call. Like I said, I call my rheumatologist all the time. I call my pathologist all the time. I let them know, hey, Kelly, listen, what do you think is under this microscope? This is how the patient is presenting. And then I'll say, hey, Johnny, what do you think about this patient's antibody panel? What do you think? This is important, right? Pulmonary, radiology, pathology, rheumatology, primary care physicians, all right? Respiratory therapists can be included because they're the ones at the bedside taking care of these ICU patients. I think it's important to teach them and allow them to learn things as well. So I think that ILD centers have a lot of resources, but you can do this too in private practice, right? We do it every single day. Just have that interest and have that discussion. For more information, I want you guys to visit Insights in ILD, right? We're working on this website. We're working really, really hard. This website, I think, is excellent. It's got great content. It's got great imaging. It's got great pathology features. And again, for a beginning learner, it's absolutely excellent. For somebody that wants to re-solidify what they already know, it's absolutely excellent. So I encourage you guys to visit Insights in ILD. I think it's a great site, and I hope you guys learn from it. I hope that this lecture today was very, very helpful, and I appreciate you guys' time. I know you are all busy. Thanks for joining today. I really appreciate the time.